know, this program is mainly for the postgraduates, where a postgraduate will be presenting a case and we will have detailed discussion on that subject. Today, actually, it is the 19th module we are having, and we are getting a very good response from all the PGs who are attending the program. Today, Dr. Parvati S. Nair from Chaitanya Eye Hospital, Trivandrum, will be presenting a case. And Dr. Gemini Isaac, Neuro Ophthalmology consultant, again from Chaitanya Eye Hospital, Trivandrum, will be the mentor. And we are blessed to have Dr. Naveen Jayakumar, who is the Honorable Director, Darshan Eye Care Center, Chennai. And he was the former Director, Department of Neuro-Ophthalmology, Shankar Nethralaya, Chennai. Welcome, sir. On behalf of KSOS Scientific Committee, a warm welcome to this program. And we also have Dr. Sahasranaman, sir, from Chaitanya Eye Hospital, along with us to lead the discussions. With these few words, I hand over the program to Dr. Gemini Isaac, who is the mentor for today's program. Over to you, Dr. Gemini.
Thank you, sir. Thank you, sir. Good evening, everyone. I would like to thank Dr. Bastin, sir, Chairman KSOS Scientific Committee, for giving us this opportunity. And as sir mentioned, this is the 19th module of PG classrooms, the most successful initiative from KSOS. And this time we have Dr. Naveen Jayakumar, sir, with us. Sir need no introduction to any of the ophthalmology platforms all over India. And currently, sir is working as Director, Darshan Eye Care, Chennai. And sir is the present President of Indian Neuro-Ophthalmology Society. And sir worked as Director, Department of Neuro-Ophthalmology, Shankar Nethralaya, Chennai. And sir has extensive work experience with all the pioneers of neuro-ophthalmology like Neil Miller, Walsh, Joel Glaser, everyone. And today we have our academic director, Dr. Sasanam sir, also here. And Dr. Parvati, our second year student, DNB student, will be presenting the case. And during Dr. Parvati, during your presentation, you may get interrupted by me and sir for some clarification or to ask some questions, and also to tell you what sir expect from you as PG when you were understanding about the case. And we have our other PGs also who have just completed their theory exams and preparing for practical exams. We will ask questions to them also. So I think Dr. Parvati, be prepared. So shall we start the presentation, sir? Naveen, sir?
Yeah, go ahead, please. Thank you.
Can I start, sir?
Please go ahead.
Good evening, everyone. Today, I'm going to present a case of a 21-year-old female who's a second-year MBBS student, presented with complaints of headache and pain around both eyes for 2 weeks and double vision for 1 week. History of presenting complaint. She's a known case of acute promyelocytic leukemia under chemotherapy on arsenic fluoride and all-trans retinoic acid. And she had her last cycles of chemo in February 2024. She had headache, which was more severe in the morning and associated with pain around both eyes for 2 weeks. There was no history of pain on eye movements. The headache was throbbing in nature and not associated with nausea and vomiting. She also complains of pulsatile tinnitus. 1 week later, she noticed double vision while waking up in the morning, more on distance and more while looking sideways. It was sudden in onset and was non-progressive. The two images were separated horizontally and the double vision got relieved on closing one eye. There was no history of diurnal variation. There is no history of drooping of lids, no history of transient obscuration of vision, no history of redness or photophobia, no history of deviation of angle of mouth or difficulty in eye closure. There is no history of weight loss or weight gain. There is no history of fever, no history of trauma to eye, no history of any paranasal sinus infections. She consulted Regional Cancer Center and was referred here for ophthalmic evaluation and management. Past ocular history. She has a history of using glasses for 1 year in 2022, then discontinued. No history of similar episodes in the past. No history of any ocular surgeries or trauma to either eye. Past medical history. Patient was evaluated for gum bleeding at Regional Cancer Center and was diagnosed to have acute promyelocytic leukemia post bone marrow study in January 2024, following which she was started on chemotherapy regimen, which was arsenic fluoride and all-trans retinoic acid, and completed 4 cycles of chemo on 26 February 2024. There is no history of any steroid intake or any steroid withdrawal, no history of antibiotic use, and there is no history of drug allergy. She takes a mixed diet. Her sleep and appetite normal. She has normal bowel and bladder habits, and there are no erections. Family history. There is no history of squinting or any other ocular diseases in the family. General examination. She is moderately built and nourished. Her BMI was 26.2. She's conscious in
Parvati, what is the normal BMI?
20 to 24.
Okay, you expect that this is slightly higher side, no?
Yes, ma'am.
Yes, continue.
Pallor present. There is no icterus, cyanosis, generalized lymphadenopathy or petal edema. She is afebrile. Her pulse rate was 84 per minute, regular, normal in character and volume. Respiratory rate was 24 per minute. She had alopecia and there was hyperpigmentation over the neck and her nails. Systemic examination. Cardiovascular system, S1 and S2 heard, normal. There are no murmurs. Respiratory system, air entry bilaterally equal, normal vesicular breath sounds, no adventitious sounds heard. Gastrointestinal system, per abdomen was soft, non-tender, and no organomegaly. Higher mental functions were normal. Sensory and motor system normal. And coming to cranial nerve examination, olfactory nerve, smell perception normal. Second, third, fourth, and sixth cranial nerves will be dealt later. Trigeminal nerve, sensation over face normal. Muscles of mastication normal, no jaw deviation. Facial nerve, wrinkling of forehead normal, no facial asymmetry, no deviation of angle of mouth noted. Vestibulocochlear nerve, no hearing impairment. Glossopharyngeal and vagus, no difficulty in swallowing. Uvula was central. Spinal accessory, there was normal shrugging of shoulders. Hypoglossal nerve, tongue movements normal. There was no fasciculations or wasting. Deep tendon and superficial reflexes were normal. No cerebellar signs noted. Gait was normal. No signs of meningeal irritation. And musculoskeletal system was normal. Coming to the ocular examination, this is orthophoric in primary gaze and there was esotropia on right and left gazes. There is no head tilt, face turn or chin elevation. No ptosis, proptosis or nystagmus. Extraocular movements, ductions in the right eye showed -2 limitation of abduction. All other movements were normal. In the left eye, there was -1 limitation of abduction. All other eye movements were normal. Versions, there was a limitation of levoversion and extroversion noted. All other movements were normal. Visual acuity, uncorrected distant visual acuity was 6.6 in both eyes. Dilated retinoscopy with 0.8% tropicamide and 5% phenylephrine drops at 2/3 meter as working distance showed, plus 1.5 diopter in both horizontal and vertical meridian in both eyes. Color vision by Ishihara was normal. Hirschberg test was orthophoria. Cover and uncover test showed esotropia in side gazes, and Woodford test showed fusion. Coming to the anterior segment examination of right eye, lid and index are normal. Rhoplas was negative. Conjunctiva normal. Sclera normal. Cornea normal in size, shape, and luster. Anterior chamber Van Herrick's grade 3. Iris normal color and pattern. Pupil was normal in size, round, regular. Direct and consensual light reflex was brisk. No relative afferent pupillary defect was noted. Lens was clear. Intraocular pressure by Goldman applanation tonometry was 12 millimeters of mercury at 12 p.m. Not on any medication. Anterior segment examination left eye. Lid and index are normal. Roplas negative. Conjunctiva normal. Sclera normal. Cornea normal in size, shape, and luster. Anterior chamber Van Herrick's grade 3. Iris normal color and pattern. Pupil was normal in size, round, regular. Direct and consensual light reflex was brisk. No relative afferent pupillary defect noted. Lens was clear. Intraocular pressure by Goldman applanation tonometry was 12 millimeters of mercury at 12 p.m. Not on medication. The fundus examination of right eye with distant direct ophthalmoscopy, a red glow noted. Fundus examination of right eye with 90D and indirect ophthalmoscopy, media clear. Optic disc appears elevated of 3 diopters. Disc margins were ill-defined with 360-degree blurring of margins. Vessels over the disc was obscured. Cup was obliterated. Peripapillary edema present. Splinter hemorrhages noted inferiorly and supranasally. Foveal reflex present. Background retina appears normal and the periphery was within normal limits. Fundus examination of left eye with distant direct ophthalmoscopy, red glow noted. Fundus examination of left eye with 90D and indirect ophthalmoscopy, media clear. Optic disc appears elevated of about 3 diopters. This margins was ill-defined and there was 360-degree blurring of margins. Vessels over the disc were obscured, cup obliterated. Peripapillary edema was present. There was multiple splinter hemorrhages noted over the disc. Foveal reflex was present. Background retina appears normal and periphery was within normal limits.
Dr. Parvati, how will you know that it is 3 diopters? How will you make it out?
With direct ophthalmoscope, we first focus the vessels over the retina and then focus the vessels over the disc, and the difference between the two will give the value of diopter value.
Okay, continue.
Summary: 21-year-old female diagnosed case of acute promyelocytic leukemia on chemotherapy with arsenic fluoride and all-trans retinoic acid, presented with headache and periorbital pain for 2 weeks and double vision for 1 week. Uncorrected visual acuity was 6.6 and 6 in both eyes. There was -2 limitation of abduction in right eye and -1 limitation of abduction in left eye. The rest of the extraocular movements were full. Anterior segment examination were within normal limits in both eyes. Dilated fundus examination of both eyes showed elevated disc of about 3 diopter with ill-defined and 360-degree blurring of disc margins. Vessels over the disc obscured and cup obliterated with peripapillary edema and multiple splinter hemorrhages. This was suggestive of bilateral disc edema.
Just before this, can we, I just like to, a few points during the examination, some of the slides. So if you don't mind, could we go to the first slide again, please? Right to the beginning, so that we'll just go through a few things. Yeah, this is fine. So as you mentioned, you noted headache, and then you also noted, go to the previous slide, please. And pain around the eyes and double vision for a week. I think that's fine. Next slide. Yeah, so in the you had mentioned the diplopia more on distance, etc., more looking sideways. So what is the significance of that? What conclusions do you draw from 1, 2, 3, 4, 5? Point number 5, the last but one point. Double vision while waking up in the morning, more on distance, more while looking sideways, sudden onset, non-progressive. So what can you, if you were Sherlock Holmes, what would you pick up from these points? Just what do you think about that history? Can you get some clues as to what she may be having from that particular history?
Venous congestion.
No, I'm talking about the double vision, no? That So,
Dr. Parthi, which can be involved like that.
let me rephrase this. What is when someone says diplopia, and then let's say horizontal separation of images, or let us say there's a patient who comes to you with double vision, okay?
Yes.
And let's say you are in the neuro-ophthalmology department, and this patient has been referred from some other department, a general ophthalmology, saying double vision, go and meet Dr. Parvati, she's an expert at this. Okay. So what is the first thing that you would do when you have such a patient? You'd ask them about the double vision and what they're feeling. But is there something that may tell you that really this is not my area of concern and this can be sent back to the general ophthalmologist to manage, or is this really a neuro-ophthalmologist issue? Is there anything in that history or anything that you can do to confirm this? Essentially, what is the first thing that you do on examination when a patient complains of double vision?
Cover, uncover.
Oh,
Yes.
for what?
For looking squint, whether there is squinting, phobias.
Okay, let me put it this way then. Double vision, yes, it can be due to cranial nerve palsy. Can someone with a cataract have a little bit of a double vision?
Yes.
What about macular disease? Can they have a little bit of?
Yeah. Yes, they can have.
And sometimes a little bit of a blur, a second image. You can also get in a little bit of a dry eye and eye fatigue and these kinds of things as well. So, So one side is a cranial nerve palsy, which is some cranial nerve is affected. The other side is these other things. So how do you make out from the patient's symptoms and do something very simple, which will tell you that this is a cranial nerve or muscle related issue and not a cataract?
With closing one eye.
So you close one eye and then what happens? Okay, now I closed my left eye.
Yeah, if the patient still has double vision, then can be due to
So
cataract.
you're asking me whether I'm still having double vision in my right eye, correct?
Yes, yes.
Now, suppose I say, yes, I'm still having that little problem. What does it mean?
More of cataract, more of macular.
So what is in scientific language? What are those two kinds of diplopia called?
Uniocular and binocular diplopia.
Correct. Monocular versus binocular. So that is a very, very first thing that one does. Is this a monocular diplopia? In which case, this is not the neuro-ophthalmologist problem. It may be dry eye, it may be corneal issues, it may be cataract, it may be some additional large PI somewhere, or a macular disease, whatever it is. The problem is arising within the eye.
Yes.
But whereas if the patient, if you close the left eye, he says, I'm seeing single, and you close the right eye and says, I'm seeing single, and now when I open both eyes, I'm seeing double vision now. That is binocular diplopia. And that is definitely our concern. We need to get it. Okay, so that is one part of it. Notice double vision while waking up in the morning. Okay, I understand, probably sudden onset. What does more on distance signify to you? So general thing is, of course, I think you mentioned more on looking sideways. Yeah, that's right. So what does more on distance and less on near mean to you? Okay, let me put it this way. Suppose there's a patient saying horizontal diplopia. I'm the patient, I'm looking at you, and I'm having horizontal diplopia now, and you're asking me which side, and then I say, when I look to the left side, now I'm getting more double vision. When I look straight, it becomes less. And looking to the right this way, I'm not getting double vision. So the double vision is here on my left, here this way. Okay. So what does that tell you? A horizontal diplopia when I am looking to my left. Both my eyes are turning leftwards. So when I'm having horizontal diplopia this direction, what conclusion can you draw from that in terms of the which muscles are involved?
left lateral rectus and right medial
medial
rectus.
Something is underacting in that direction, correct?
Yes.
So similarly, so like that way, the simple process of asking this one question that I'm having double more on the left automatically is narrowing down your choices to two muscles. That horizontal diplopia is more this way means left lateral or right medial rectus. Similarly, someone who's saying diplopia more for distance, as this young lady has, what does that mean to you? So basically, this double vision which I was having, say to my left, is so in the direction of the weak muscle, isn't it? Either the left lateral or the right medial rectus. In that direction, when it is working, if the muscle is weak in that direction, that is where the diplopia will be the most, thanks to reason. So what kind of diplopia will be is worse on looking at distance? So which means the question is, how do our eyes behave for distance vision? What do our eyes do?
Diverge the rays.
Divergence, correct. When you bring it near, it's convergence. When you look far away, it's divergence. So what are the muscles involved for divergence? Which muscles? Both eyes have to turn outwards, isn't it? From near, they have to look straight, means they have to turn outwards. So which muscle pulls your eye outwards?
Lateral rectus.
Abduction, lateral rectus. So the meaning of a horizontal diplopia, more on divergence, suggests a lateral rectus palsy. All this you can just collect by the 3 lines that you have written there. Okay. So you should, as a history is going, start thinking about what this lady might be having. Okay. The moment someone says, now that you're thinking that this is a lady with double vision of sudden onset for a month, and she also now has, you just asked a couple of points ahead that there was headache. Now, headache is something that you get, I get, Dr. Gemini gets, and all of us get at some point. Okay. Maybe preparing for this case presentation might have given you a headache also. We don't know. That will go away after another 1 hour. You'll be fine, isn't it? So how does this particular headache make it more significant? Is there something that is making it more significant neurologically? Is there anything else in those points there? Points number 3 and 4 and all that.
Constant headache throughout.
Okay, constant headache. So as I was mentioning, headache is something that all of us can get, correct? So just because someone has headache doesn't mean they have raised intracranial pressure, isn't it? Everyone doesn't have that who has a headache. Similarly, nausea and vomiting, someone who has a migraine can also develop headache, nausea, and vomiting. So if you say headache, I would ask the patient then headache with nausea and vomiting. Is this a migraine patient, for example? Who knows? We don't know, isn't it? So you need to ask whether any flashes or any spectra or anything which may help you to say this is a migraine kind of thing. Do you have photophobia, phonophobia? Patients don't like loud noises. They don't like lights and sounds. They want to go to a dark, quiet room and sleep it off. So these are things. Does it come and go? Are these episodic? That way,
Yes.
But there is one particular point that you have mentioned, which clearly tells me this is not eye strain. This is not stress headache. This is not a migraine. What is that point on this slide which tells me that? That is point number 4.
Pulsatile.
Yes. Pulsatile tinnitus is not seen in all these other conditions. You don't get pulsatile tension in stress headaches. You don't get it in migraine. Okay. Which is the other symptom which is of equal significance that tells you that this headache is, say, due to raised intracranial pressure? Very common symptom. I ask all my patients when they come back for reviews for IIH treatment. First question is, do you have this particular symptom? So if your treatment is good and is working, they say no. You ask that on the next slide. Can you go to the next slide? What is this point here?
Transient obscuration.
Exactly. What do you understand? Because transient obscuration of vision or amaurosis, you can get in migraine, you can get in this thing, a blood clot in your retina, a retinal vessel.
Yes.
Can also produce yeah, the moving embolism can produce this also. So how does the transient obscuration of vision differ in a migraine from a blocked retinal vessel to say IIH? Is there anything?
IIH, there will be in only few seconds of transient obscuration.
Precisely. If
My,
amaurosis due to a little clot or something or an embolus,
5 to 15 minutes.
yeah, not more than about 5 to 8 minutes or so. Okay. And migraine,
More than 15 minutes or
15
20
to 20
minutes.
minutes or so.
Yes.
Yeah. So that's good. That's good. So the presence of pulsatile tinnitus and the presence of the absence here in this case. So ask these two questions. So now I have a headache with pulsatile tinnitus, and now my mind has gone automatically that at this point, at the second slide itself, is this patient might be having
Increase.
of some kind. So my antennae have already gone up there just based on that history. And add to that the sixth nerve palsy, which is there, which based on that history. So as you can see here from the very two first slides, your entire case is already there that way. So why I'm stressing on this is the history is very, very important. And the meaning of that history is important as well. Okay.
Okay.
Go ahead to the next slide, please. Now, correct. Now, obviously, because she had AML, you've asked all these questions. Next slide. Next one. Okay. Now, if you say she has got papilledema, I'm going to probably see papilledema. I don't know. At this point, I don't know because I'm only asking history. Maybe papilledema with sixth nerve palsy, maybe raised intracranial pressure producing the headache, pulsatile tinnitus, diplopia. Okay. In this slide, in the treatment, is there anything of significance?
Treatment with all trans retinoic acid.
Why?
Hypervitaminosis can cause papilledema.
Exactly. So hypervitaminosis, all trans retinoic acid is a form of vitamin A. And long vitamin A treatment, chronic treatment, etc., is one of the reasons for raised intracranial
Yes.
pressure. Right. Okay. So that again is a red mark there. Okay. I will probably put a red flag over that area as well. Okay. So three things: headache with pulsatile tinnitus, a diplopia which is worse on distance and horizontal in nature. Three, patient on AML with all trans retinoic acid on treatment. So these are the three things which stand out to me right now. Now go to the next slide. Okay. Is there anything about sleep that you asked? Why is sleep important in this context now? Or maybe not in this AML case, but generally say in an IIH patient, why is sleep important?
Obstructive sleep apnea.
Exactly. So is there some other question like you'd like to ask the patient regarding their sleep?
The patient is getting up from sleep for breathing.
Yes, and they're snoring and these kinds of things. So obstructive sleep apnea is quite often underdiagnosed because we don't bother asking for it very much. So that is important to remember. Okay. Next slide. Okay. Family history. Next one. Okay. So one other thing about the BMI, so she's 156 centimeters, 64. So it's slightly higher. Okay. Did she look kind of obese to you, or like was it just normal looking and we all have a little tummy? So my weight is maybe 3 kilos over. Did she look overly obese or something like that, or not much?
Not much.
The reason I ask is that yes, BMI is important and all that. You should probably read a little more and note that down in case someone asks you in an exam. But generally, in terms of practice, just keep your eye open for this. That the typical IIH patient who comes, which description is a middle-aged lady who's very, very overweight, obese, really big, comes and says, and she's a pap lady. These are the patients who benefit from weight reduction. But there are these maybe slightly younger person. It's not terribly overweight, it's not like an obese person, etc. There, your antennae should go up a little more, and you can't really blame weight increase and obesity, even though technically you want to say this is obesity because BMI has gone up or whatever. But patient is not obviously obese. These are patients whom you should be a little more careful about. Is you can't put the blame on this kind of a BMI. Slightly more. 64 kilos, young person is not really very heavy, really, at all. So that again is flagging me that this is not an obesity kind of an IIH thing. Okay. Next slide. Yeah. I think here, because you're an ophthalmologist, you can go over the next couple of slides. And carry on. Yeah, stop here. So I think you should present the ocular part first, because that is what the patient has come to you for. So after all that history, family history and all that, you go to the eye examination. Having finished the eye examination, then you go to CNS examination, because that's how normally you would do it. Every patient with headache and double vision, you don't start with the central nervous system and higher functions and all those things. You finish your eye examination and then you say, okay, I need to check the CNS, and you do a quick CNS examination. In this picture, whenever they show pictures like this, it's good to comment on something that you had mentioned earlier. What is it that you'd like to say about this photograph, which stands out?
Alopecia.
Exactly. Yeah. Alopecia. You mentioned it in the text earlier, but I think it's important that when you're showing a photograph like this, I think you mentioned she's got alopecia. That's what is a very prominent external examination finding here. Okay, next slide. Yeah, I think this was okay. And you can see that mild abduction limitation in the right and on the left side as well. I think the next slide showed the left eye also. There you go. That way. What is the importance? This is the ductions. What is the importance of horizontal movement, the saccadic movements here? If I saw the patient like this, I would do saccades. Why is saccades important? You must have done a pursuit, no? Look maximum this way, look maximum, look up and down, follow the finger.
Yes.
If you do that fist and finger, look this side, look at my face, look here, look at my face. What is it that you would see that may help you in trying to determine what that limitation is on abduction? What is the importance of saccadic speed?
Low saccades.
So suppose that, for example, you can have abduction limitation if a medial rectus is very thick, like in thyroid disease. It is not allowing the eye to turn outwards fully. That also is limitation of abduction. What is the difference between that limitation of abduction and a limitation of abduction due to, say, a sixth nerve palsy? This is another important thing you need to remember. Why is saccadic speed important and what does it mean? Okay, so the thing is this, I will show, maybe once this presentation is done, I'll show you one video, just remind me. But it is important to see the speed at which the eye moves. Yes, there is limitation and eye will only move to that point. But how fast does it move to that point? So you can compare the abduction of the right eye with the adduction of the left eye, because on a gaze, isn't it?
Mm.
If you're looking to the right gaze, for me, this is my right eye. So I'm looking to my right. What happens is my right eye is abducting and there's limitation there. The left eye is adducting. My point is not about how much limitation is, the speed at which the eye moves to take up that position. So in a thyroid disease, there is no nerve palsy or anything like that. So movement, even though there's limitation, the speed of movement is normal. The speed of the saccade is a reflection of the integrity of the nerve. So in a nerve palsy, that speed will be slowed down. Saccadic speed will be slow. So there's an important differentiation between a paretic muscle and a non-paretic muscle, like muscle thickness or restrictive palsy, for example, So that's important to know and important to do in this patient. Next slides. Let's go to the fundus. I think the rest of the examination was all good. No comment there. Yeah. So one of the things they will ask in the exam, which is the kind of thing we mug up and go, and it's important to remember, is the grading of papilledema. That way. So you are remember the grading, grade 1, 2, 3, 4. There's a scale grading of that. Huh? So just know that as well. The other thing about the obliteration of the cup. Why do you think the cup is obliterated?
Because of the elevation of the disc.
So here, if you see, you can point to where the cup is there. So that little area there, to me, it does not look obliterated. My feeling is there is a small cup there, maybe 0.1 to 0.2. The only thing is, I have a feeling that this particular nerve itself is not a very big optic disc. It's a slightly smaller optic disc and a slightly smaller cup. So cup obliteration, although here it is looking small, cup obliteration in papilledema happens only in the late stages. That is because of gliosis. Gliosis grows over the cup, fills it up, it threads along the blood vessels, so you get sheathing and all these kinds of things, So it's a late stage thing, all right? Now, when I see a patient in the history that you described, let's suppose this patient had got counting fingers at 3 meters in both eyes. It presented to you with counting fingers at 3 meters, drop in the vision 2 weeks ago, and this is the examination. Is there any, what conclusion will you draw from that?
To say to the macular edema heart.
Here there is no macular edema. I'm talking about exactly this photograph. This one and the left eye. But the patient does not have 6/6 vision like you described. The patient has got 3 meters vision.
Ischemia of the...
So the question is, it could be some kind of an optic neuropathy. Correct. Because why do we say optic neuropathy? In papilledema, until the late stages at least, the vision is preserved. Like in your case, 6/6 vision with bilateral disc edema does not fit a optic neuropathy. It fits a papilledema. Similarly, 3 meters vision with bilateral swollen discs is not papilledema. It is optic neuropathy. Of course, one can never say, there is no rule that a patient with optic neuropathy cannot have papilledema. They can have both also. And once or twice in my life, I've seen a few which mixes up the two things. But it's important that is one of the things they teach you, or if you do any talk on disc swellings, bilateral disc edema with vision loss is an optic neuritis or a neuropathy of some kind. Whereas bilateral disc swelling with normal vision is a papilledema. One of the differentiating things. Yes. The reason why optic neuropathy is important if the patient had drop in the vision is because of AML. He has acute myeloid. AM?
So,
Yeah, AM.
AM.
Yeah, so if she has that, in that setting, you can get infiltration of the cancer on the optic nerve. You can get infiltrative optic neuropathy, which may look a little bit like this, where you barely see any disc at all. And you can get, in fact, even more hemorrhages over the place. You literally, the architecture of the disc is masked. You can't make out. There's some lump of various blood clots, something and all that. So something like this, you need to keep in mind that is there an infiltration of the optic nerve as well, particularly if there's a visual drop associated with it. Okay. Let's move on to the rest of it. So now you have a headache, pulsatile tinnitus, normal 6-nerve palsy bilateral, and a disc swelling, bilateral papilledema. What is your next line?
For
Just say 1, 2, 3. I would like to do this.
first is investigation, going for investigation. MRI, brain and orbit, neuroimaging.
The patient is in your room. Okay, you finished your examination. What is the next thing? You've dilated the eye, you've looked inside. Okay.
Diplopia charting.
Yes, okay. Let us say you have to ask the patient. Now, of course, eye is dilated, vision may be a little blurred. You may not be able to do it, but diplopia charting, fair enough. Then
Visual field.
very good. Visual fields. Especially if it's blurred, you can always ask them to come the next day when the pupil is small so that they can see better and they can do a better field. Good. Now it is dilated. Is there anything else you'd like to do?
OCT or nothing.
Why do you want to do OCT now? What do you think the OCT will show you?
Thickness, average RNFL thickness.
What would you expect?
Increased.
Correct. And is that something that you can't see here?
No, I can't see.
Correct. So for me, OCT at this point in time is really not helping me in any way. How did that help you now to, does it change your diagnosis or help you for future management? Not right now.
No.
Where does OCT get useful in IIHs when it's already settling down and we are going to pull away diamox, for example? Then I want to do OCT because the disc is almost flat. And then I want to know how high the elevations are because I'm going to pull away the medicine. I don't want it to increase. So a subtle increase happening later, I can track on OCT. Here I can see it with my naked eye itself. So it's not really going to happen. What is better than an OCT is a fundus photograph, like the one that you've taken now. This is very, very useful because you can follow it up because it's going to change over time. Okay. Visual field, what kind of visual field? You have to be a little specific. What would you like to do?
Single field, central, 30-2.
Fair enough. 30-2 is acceptable. Yes. And what do you expect to see on that field?
Blind spot enlargement.
Okay. And why do you think the blind spot gets enlarged? In papilledema, why is that blind spot enlarged?
Because of the mechanical displacement of the peripapillary retina.
Absolutely right. Well done. Yeah, that's good.
Then Stiles-Crawford effect.
Okay, yes. So be prepared for that particular question. Okay, so next slide, carry on with your thing. So you did we said we'll do fundus photo, which you've done, and you said we'll do the field. And let us see the field now. Your diagnosis, why don't you just go back and narrate what you want to say here? Summary. Yeah.
Clinical diagnosis, established papilledema with bilateral lateral rectus paresis. And differential diagnosis, idiopathic intracranial hypertension due to hypervitaminosis or leukemic disc infiltration.
Well done. Well done. Good. You've actually written leukemic disc infiltration. You should say that. Be confident. You have all the answers up your sleeve. All right. Next slide. Carry on. Go ahead.
diplopia charting done, shows horizontal maximum separation in levoversion and extroversion, testing bilateral lateral rectus palsy.
Yeah, one of the things that they will, especially the older examiners would ask you, I'm sorry, I'm actually old. My teachers would have asked me to write here is on which eye is the red glass for the diplopia?
Right.
So you must say, somewhere you must note down, this is a diplopia chart. You already put down right and left, which is good. And you must say red before right eye.
Okay.
It's a convention, but it's also good to note it.
Okay.
Red is before the right eye. Okay, yeah.
The single field analysis in 30-2 Humphrey of right eye showing with good reliability indices showing blind spot enlargement.
Good. Next slide.
The left eye showing blind spot enlargement.
Okay, good. Now what would you do?
Now going for a neuroimaging.
Okay, what kind of neuroimaging would you like to?
CT to rule out intracranial space occupying.
You'd like to do a CT. Okay. Any particular reason for preferring CT? What is the other investigative modality?
MRI.
Okay. So why CT over MRI?
To show more of intracranial space occupying lesions or bony infiltration.
Are you suspecting some bony
Infiltration?
Because in an IIH, what is it that you want to see?
The ventricles, whether this.
Okay, you want to see ventricles. Anything else in the orbit?
Perioptic space.
Perioptic
widening. Yes.
Suppose this lady did not have AML. Okay, just exclude it. Middle-aged lady with increased weight with papilledema. Okay, what else do you see? Perioptic space, maybe narrowing of the ventricles, widening of the perioptic spaces. Then point number 3.
Posterior flattening of sclera.
Okay, yeah, that's good.
Then empty cella.
So the pituitary is squashed down a bit because of the pressure is squashed. So you can get a partial empty cella. And the 5th is very important. All this you can see on the MRI. Okay. The 5th is something you have to do additionally. What is that?
MR venogram.
What do you see on the MR venogram? Venous, sinus, what? What can you get? There are one of two things that are possible. So it can be either sinus stenosis or thrombosis. One of the two, stenosis or thrombosis. Okay. So it's very important in this case. A lot of people forget to do the MR venogram. So a papilledema with raised intracranial hypertension kind of diagnosis, MRI is the preferred choice, not CT scan. CT doesn't really help us here. It's MRI with MR venogram. Okay, let us say for some reason MRI is impossible to do, patient can't afford, only CT is available, take it and do it because it is better than nothing at all. That way. Because at least the CT scan will show you that, for me, it will tell me there's no tumor inside. It's not going to help too much with anything else, but and maybe narrowed ventricles, but some patients with IIH have normal looking ventricles. It's a very subjective thing. And the other things is very difficult to make out that way. So CT may not be very helpful there, but better than nothing at all. But when you have access to MRI for choice, it is MRI. So don't say CT scan. Okay. MRI with MR venogram. Now, assuming this is a middle-aged lady, like I said, not, before she leaves your consultation room, is there something very simple you can ask the sister in the ward to do?
Blood pressure.
Exactly. Do not do an MRI until you go. Otherwise, the first thing you want to do after examination and seeing all this, is to pull out a requisition form to your scan center to fill it up. Please avoid that temptation. Send the patient. It's very easy to forget. Send the patient, check the BP. And we are not talking about BP of say 160 by 100 and that kind of blood pressure. We are looking at 200 and something by 120 and that kind of very high malignant kind of hypertension issues. These people are walking time bombs. Any moment they can go for a stroke. So your duty is to rule that out. Forget about MRI, AAV, all that. Send the patient to a general practitioner or a hospital. They need urgent control of blood pressure. That okay. So let's carry on and see what you got for us now. Go ahead.
No, CT RNFL showing increased average RNFL thickness in both eyes.
Yeah. As you can see, that black line is shooting out of the graph itself, which is to be expected. I mean, it's so much elevation is there, isn't it?
Yes.
Okay, where would OCT RNFL or OCT of the disc be useful in this situation? One particular reason, if you're suspecting something else, a cross-section of the disc. Why is a cross-section of the disc important? More than say RNFL, cross-section. What is the differential for papilledema?
Optic disc drusen.
Exactly. So it may help you to figure out if there is a drusen or something like that. Okay. Okay. Go ahead.
Neuroimaging done. MRI brain and orbit. This is in
Okay.
cell.
Let's talk a little bit about this and see what you know. It's useful to read. So let's take the picture on top. Can you point that? That's that picture. What kind of a picture? Someone asked you to describe this picture, or in an OSCE, if they put this up and say, describe this image. What is it that you're seeing? What is it? First of all, is it a CT or an MRI? Correct?
It's an MRI.
MRI of?
Orbit, brain and orbit.
Okay, good.
Axial view.
Very good. Axial section.
T1, wait.
Okay, why do you say T1?
Vitreous is white.
Fluid is dark. Very good. Fluid is dark is T1. I'll show you something else. How do the extraocular muscles look? Dark or white?
White.
White. Okay. Now, in that image, just behind the orbit to the brain, can you see these little white dots here and there? Can you point out one or two to me? There. And then in the brain, in the dural area also, there is a few. See yeah, that one there. And in the corners and the sides also, you can see a few. What are those? Because to me, these little white dots indicate contrast in the blood vessel, at least. So this looks to me like a contrast gadolinium imaging of the brain, which is why it is done on gadolinium imaging is always done on T1 images. The contrast series, that will explain these. So one of the things is the extraocular muscles will enhance on contrast. And you can see these little dots in the brain here and there. That is the contrast in the blood vessels that way. But okay, does this show any flattening of the sclera or anything like that? Not little bit maybe there. Yeah, that way. So actually, if you want to see widening of the perioptic spaces, it's not very clear here on this image. What kind of picture will be better?
Coronal.
Exactly. Coronal section, especially a T2 image. T2, the fluid will look bright. Okay. And if they fat suppress the orbit, so the fat will look dark and the fluid will look bright. And you can see that very clearly in coronal sections. Okay. See, even here in the pictures below, you can see that sagittal view in the second picture on the left. You can see all those white dots. Can you see that on the top near the dura? Those are all blood vessels being filled up with contrast. Okay. Anything that you'd like to point out there or something?
Narrow ventricle.
Narrowing of the ventricle is better seen on an axial scan. Okay. But what about the third picture? Yes, the one bottom. Yeah. What are you
Em-
showing there?
Empty cellar.
Empty cellar. Okay, that is good. Can you see just above the cellar that there's a horizontal, that way you're pointing, that horizontal line there? Yes, on the top. Yeah, what is that?
Dorsum cell.
No, no, no. What is that structure? What is above the pituitary gland? 11 millimeters above the pituitary gland. I think it's 11. You can check it out. See. Very, very important for us. That is the optic chiasm. Please remember that when you see the pituitary, go and point that structure again. Show it to me again. I can't see your mouse. Your mouse is stuck somewhere. You're moving it. No, that's not that one. Where is the optic chiasm? That is the leave it there. That is the that thing positioned like this horizontal line. That is the optic chiasm above the cellar testicle. Okay, good. All right, go ahead.
CSF study was done, showed CSF opening pressure of 29 centimeters.
MR venogram is a different set of images that you've not. I don't think you have it with you, correct?
No, sir. Imaging we don't.
You don't have that. Okay.
Normal according to the.
Okay.
This
CSF show?
Showed a CSF opening pressure increase of 29 centimeters.
And what would the normal be?
25, less than 25.
Around 20 to 20. Yeah, correct.
No.
Of water. Please remember that unit. Okay. More importantly, about the composition of the CSF.
No atypical cells and normal composition.
Yeah, so it's important to talk about the protein and the chloride and all these things, because that's also important, because if there's any infections and all that, these numbers will get altered. Okay. So composition is normal. Okay. All right. Then. So what happens now?
We'll start treatment for papilledema.
And what would you like to treat her with?
Oral acetazolamide, Diamox 250 mg.
Diamox, how much would you give?
250 mg BD.
250 mg BD.
3 times per day.
Okay, so what is the recommended dose generally for IIH to reduce the pressures? You can go about, it's almost about 1 to 1.5 grams a day. But if you give 1.5 grams to your patient and say, here, take this from tomorrow, she's going to come and throw it all back at you because she can't swallow that much. So you're right. You start at 250, that is 1 tablet twice a day. And after maybe about a week, make it 3 times a day. And after another week, make it 4 times a day. And after that, build it up slowly. Okay. Is there anything else that, by the way, this imaging, before I forget, one other thing, useful thing with the contrast injection is it can show you involvement like secondaries in the dura, like deposits, cancer deposits, etc. Sometimes you can get that. So that is why this particular imaging with contrast is very useful as well. That way. So I think it's an important distinction that if you're dealing with a plain vanilla IIH middle-aged lady with obese thing, papilledema, MRI with MR venogram is fine. You may not need a contrast at all. But in a younger person with some leukemia issues, etc., better to do it with contrast because you never know what you might pick up. Right. All right. So build up the Diamox. Anything else you'd like to give along with the Diamox to reduce the side effects?
Pantocid.
Pantocid. Okay. Any electrolyte issues caused by the Diamox?
Potassium.
Exactly. So potassium can get low. So you can give them a potassium supplement or ask them to eat some potassium-rich foods like a banana is good. Tender coconut water is good. So these things are a little helpful also. And I assume, therefore, you sent this to the neurologist for that, who would have done the LP, isn't it? They must have seen.
Yes.
Okay.
Yes.
Good. So I think you have approached it correctly. You made the right diagnosis. And let us say, when did you see this patient, Parvati? Did you see it recently, or has it been treated for a while now?
She's seen last year, sir.
Last year. So what happened to her?
Um, she was lost to follow-up, sir. She
Oh dear. Okay. So after this, we've never really seen her then.
No.
Okay. Okay. So how would you follow up this patient? Let's say she was a good patient and she kept coming back. What would your plan be? Okay, you're treating with Diamox, you've gone to maximum levels. What would you expect? That the papillary edema will reduce.
Decrease.
So periodic eye examination, say once in 3 weeks or so, it goes down. And then you can follow up. Now you have photographs. You can take pictures. It helps you in your diagnosis. You can just flip to your previous photo. You'll know how it looked like last time when she came to you. That way. So always remember, a picture is worth 1,000 words. Rather than putting full descriptions, one photograph is useful that way. And when the disc edema comes down to almost normal and you're tapering the steroid, that's the time to do the OCT, RNFLs. Because you want to establish this is the new baseline, and I'm going to compare my future disc elevations with what I'm getting today when the disc is all looking almost flat on the front disc. That way. Okay. Suppose Diamox is not working.
Done. In
How do you know Diamox is not working?
There is no reduction in.
No reduction, or maybe a mild one is getting worse. Okay. And then symptoms?
There'll be headache, constant headache.
More than the headache?
Double vision.
More than the double vision? What is the vision related one?
It'll go down. Visual acuity will go down.
Vision drop. Before vision starts to go down, what happens? What symptom will the patient have? Something she doesn't have now, you mentioned in the beginning.
Transient.
Exactly. Transient visual obscuration lasting a few seconds. Every time your IIH patient walks back to you for a review, ask them this first question as they're walking in. Do you have any TVL? Do you remember what I asked you to tell me first?
Yes.
Keep on reinforcing that idea so that it's stuck in their head that any TVL, they come and report to you.
Yes.
Please remember that once the vision starts to go down, it can go down fairly rapidly over 1 or 2 weeks also. The optic nerve can just collapse and give way. And whatever you lose is not going to come back. So prevention is very, very important to recognize when treatment is not working or is ineffective. If treatment is not working, sometimes patients with very high CSF pressures right in the beginning, they do therapeutic tap also. Just bring down the pressure quickly. You want to save the nerve. Suppose medical treatment is not working, what is the surgical treatment?
Shunt surgeries to reduce
What
the
kind of shunt do you do?
Ventricular
Shunt is from one area to A area to B area. So which is A, which is B?
Lumboperitoneal.
Lumboperitoneal. Okay. What is the other kind of shunt? What is a TP shunt?
Thoracoperitoneal.
Not thoraco. THECO. THEC. Or sorry, VP shunt. Ventriculoperitoneal. Yeah. Ventriculoperitoneal or lumboperitoneal shunt. These are the two. Usually it's an LP shunt. What about the dural venous sinus? Suppose it's a venous sinus stenosis. What would you do? Is there some other surgical thing? So actually they measure the suppose this is the area of the stenosis, okay? This is the venous sinus and here it becomes narrow here, this area. So this is normal and then it narrows like this here. So what is the pressure here and what is the pressure on the other side of the stenosis? This side and this side, and this in-between bit is narrow. That is important. Because normally the difference between the sagittal, superior sagittal sinus and the internal jugular vein, jugular bulb inside, the pressure differential is usually between 0 to maybe 3 or 4 like that, around 3. Okay, not more than that. So if there is a pressure differential of more than 4 or 5 or 6 like that. Sometimes it's 15, 16 and all that you can get. Those are very significant pressure differentials. And that will just not doing a shunt may not help you. You may have to put a stent between these two. And the stent helps to bring down the pressure differential and brings it down to maybe around between less than 4 is good that way. So that helps in the management of IIH. Okay. The other thing which they will always do, and it's good for you to remember, not just for the neurosurgeon to remember, is before you touch the patient surgically, we always do a DSA, digital subtraction angiogram. You never know which of these patients has an AV malformation producing this that way. Because we've had one patient like that long ago. After shunt also difficulty, they did 2-3 shunts, all sorts of things. And the patient had an occipito-parietal AV malformation causing the IIH papilledema that way. So all patients, before they do surgery, it's a good thing to do a DSA. Rule out that because the management of that is completely different. You can't simply just do one shunt and leave it alone. You have to tackle the AVM first. Okay. So that's good. It's very well done, well presented. I would prefer probably the MR venogram pictures also to be shown because that's important. And yeah, so that's about all I have right now.
Thank you.
Thank you. Dr. Gemini, would you like to say something?
Thank you, sir. It's a very elaborative discussion, sir. We also learned so many things from your discussion and questions, sir. Thank you so much, sir. Actually, we are blessed with your presence, sir.
Thank you.
KSOS and we people, we PGs, mentors, all benefited from the class, really, sir.
Yeah. So
I would say better than elaborate, no, meticulous. That was the word I would like to put, sir. Always your discussions, sir. Always your discussions are very, very meticulous. Very, very good.
So I just
and the other good thing, no, sir. Other happy thing for assistant or PG has presented well. She has answered well, and that credit also goes to the mentor tutoring by Gemini.
Yes, absolutely.
Thank you, sir. Thank you.
So I'll do one thing, if you don't mind, if you have
yes, sir. You had on my video.
I just wanted to show you this bit from my PPT. Can I just one second? I'll just share the screen. Yeah, can you see my slide here? Can you see the slide?
Yes, sir.
Yeah. So this is a patient who had right lateral rectus thickening. Okay, you can see that she's middle-aged. She's senior citizen with diabetes. She had a diplopia last year, and she had a left lateral rectus palsy, which improved in 2-3 months, like an ischemic nerve palsy. Then she came this time with the right thing. So always remember, Parvati, and think that this side here, this is the right eye.
Yes.
This is the left eye. Okay?
Yes.
It's opposite to what we think because the imaging convention is as if you're viewing the patient from the feet upwards. Okay? So this here is the right lateral rectus. Okay?
Yes.
What do you see here? Look at the right, and whenever they ask you anything unusual about the right lateral rectus or any muscle or any structure, you look at the corresponding structure on the opposite side, which is this. What difference do you see between the right and the left?
Increase in...
Yes, increase in?
Belly.
Yeah, see the thickening here. Okay, see the thickness here. See, this is a normal muscle shape, kind of a biconvex slightly. See the thing irregularly thickened all the way. But if you see this see how it thins out near the apex, correct?
Yes.
What is happening here? It's going all the way here into the superior orbital fissure. This is the optic nerve going into the optic canal. And this is the thing near the orbital apex. And you can also see some thickening here in the superior orbital fissure as well. So this looks like a myositic kind of a condition. You see that difference there. Okay. and you can always compare it between the opposite nerve. Okay. So this is the lady. Now see what she's got. You do an eye movement. Now she's looking left and then she looked to the right. Left, right. Look at the speed of movement of the right eye abduction. See that? It's going slower. And what I'll do is I'll show it to you in slow motion. You see how fast the left eye moves in and you see how slow the right eye moves outwards. See, the left is moved in, see the right is slowly drifting. This is what I mean by saying this is a slow saccade. Now, a slow saccade means that this is a
Neuro.
this is a nerve palsy also. It's not just this thickening of the muscle which is producing restriction. This is not just a restrictive myopathy. There is a nerve involvement at the sixth as well. That is why the adduction is slow. You will not get that if the muscle is thick. You'll get limited movement, but that movement will be fast. Not this very, very slow movement happening. Definitely there's a nerve involvement. The sixth nerve is affected. And combined with this, after that 1 week or so, the patient came back, was having altered sensation, right frontal pain over the forehead and things like that. And so that is why, if you look at this area, this is a superior orbital fissure, which I showed. So she's got a superior orbital fissure syndrome with first division of trigeminal and the sixth nerve also being involved. Understood? So that is a slow saccade I was talking to you about. Yeah, that's it. Thank you.
Thank you.
Thank you. Happy to take any questions or any comments. Anything anyone would like to add? Most welcome.
Sir, regarding this patient, when we did follow, the consultants from Regional Cancer Center told us that they stopped the vitamin A supplements, then she improved like that. Sir, if textbook says it is one of the risk factor, and is it that common, sir? Have you ever seen such a...
Retinoic acid is a vitamin A, hypervitaminosis A will cause this, and which is why my ears went up when I saw that name retinoic acid there. That's one of the possibilities. We can never be sure as to what exactly the cause is, but right now that is the one which is standing out in front, and it makes sense to stop that treatment along with management of the pressure. But it is very important that she comes for a review, because we have absolutely no idea how her eyes are with all this. And she is at risk of losing vision if it's untreated or not adequately treated. So it's very important to follow up these patients and try and make sure they come for a review, or at least in the beginning, you stress to them why it's important to come back to you. Otherwise, they just be going round and round and forget about you that way.
Thank you. Thanks.
Gemini, complete.
I think any other question from these others join for the class? We are happy to take questions. Parvati, do you have any doubt?
Sir has already told everything.
Sir, it was very nice discussion, like a lot of learning points from your side.
Thank you.
It was very good and very well. You said everything about that case. I think the PGs who attended this class would have been benefited a lot.
Thank you.
And I'm sure if such case comes, they will do it well. And now over to Dr. Rajesh. Rajesh is a member of scientific committee.
Right.
Rajesh, over to you for the vote of thanks.
As Sasram sir already told, today sir has discussed the papilledema meticulously. It's KSOS is very grateful to you, sir. Thank you, sir.
Thank you. It's a pleasure.
Thank you. Also, I also thank today's mentor, Dr. Gemini, and present Dr. Parvati, and also Dr. Sahasraman sir, who was our past KSOS past president. Sir was here all the time. Thank you, sir. And
he's very always very enthusiastic to take up any academic events. Previously we had one PG classroom, PG update program at Chaitanya. So sir was very much helped me to conduct that program. And any academic program, sir is behind that. Sir, thank you very much.
Thank you. Navin sir, next conference we will see.
Thank you. Thank you very much. It's a pleasure to interact with all of you, and it was an excellent discussion with Parvati, and he's presented the case extremely well, and it made it very easy for us to go through the slides. There's a certain logic to the whole thing.
Thank you, sir.
Well done. Well done.
Thank you, sir.
Thank you, Dr. Gemini and Dr. Baston and all the others, Dr. Sahasranamam and Dr. Rajesh as well. Thank you.
Thank you. And good night.
Good night.